developmental dysplasia of the hip. What do you know about that from your OB lecture? Newborn assessment, anything? That's right, Barlow and Artelani's. What else might give you an indicator? Those are some, we're going to talk about that in a minute, but what else might give you an indicator?
The folds.
Folds. So where are the folds? What folds are we looking at?
Gluteal folds.
Gluteal folds. Unevenness, right, of the gluteal folds, uneven. Now, those can all be signs of developmental dysplasia of the hip. And what happens is that in utero, the fetus, sometimes from positioning even, sometimes genetic, but sometimes even from positioning. So breech positions are more likely to have this actually. Their hip does not develop in the socket. So you have the acetabulum, and then you have the head of the femur, that ball that's supposed to sit in that, and they don't necessarily sit well. Sometimes they sit in there, but they don't stay in there so that they can dislocate as the child starts to walk, or starts to crawl, or starts to move. And sometimes they don't sit in there at all. They're just outside because that's how they developed. So it can be a complete or it can be partial developmental dysplasia, or dysplasia of the hip. If it's complete, it means it just didn't develop and it's like right here. Or it could be that it's in there, but as they start to move, it can actually dislocate. How do we check for that? That goes back to the Ortolani's and Barlow's. So I always think of it this way. So I have my little mnemonics. Ortolani is out, O-N-O. So when you do Ortolani's, you're pushing the legs, you're bending up and out, and you are actually attempting to dislocate the hips. If you hear it clicking, like click, click, you've actually popped them out, popped them back in, which is not good. You should not be able to do that. That means it's positive, which means that they have a developmental dysplasia of the hip. Barlow's is the opposite. You're bringing them inward, so therefore you are abducting, adducting, right? Bringing them in, add is inner. Adducting, abducting means when you're bringing them out. So Barlow's, you are bringing them in, and again, you're checking for the clicking. Anything that you click or hear a pop or a click of that would mean that it is positive and that they have this. That being said, you as the student would not do this. Obviously, it's usually the pediatrician or the nurse practitioner who comes to do the newborn assessment that would do this. Not even the staff nurses do these. But it's just good to know that they should be done, how they're done, and why they're done, and what they show. So if the child does have that, it's more common in females, firstborn, family history, so again, genetic predisposition and positioning in utero. Transverse or breech is more common. And again, there's ones that are just considered unstable, meaning that they're not always dislocated, but they will dislocate on movement, or they are completely dislocated, even from birth. So in either case, what needs to be done, and again, you're looking for the asymmetry of gluteal and thigh folds, apparent shortening, limited hip abduction, and stiffness. And these are the maneuvers that check for it. The treatment would be one of two options. If they're younger, they put them in something called a Pavlik harness. A Pavlik harness. That is a type of skin traction, which I'll show you in a minute. If they're older, they can put them in traction, like a hip spica cast. And then even older than 2 years of age, if they still have the issue, if they still have dislocations, then they actually will do hip surgery, an ORAF. And sometimes they'll even do what they call bipolar, which means they'll replace the head of the femur, if they need to have it. So here's an example of a Pavlik harness. In this case, we're keeping the hips in an abduction, ABD, abduction, keeping them out, okay? So if you're keeping them in that position, you're actually forcing them to stay in the acetabulum, hopefully strengthening them. They stay in this pretty much all the time. Because especially newborn up to 6 months of age, they're not very mobile. I mean, you would like them to start being mobile, maybe turning around, so that's why they do take them out for short periods, but they really can't be that mobile anyway because their hips are so unstable. So they keep them that way. Now, does it look like this is painful for them? No. I always like to stress that. Because many times, especially NCLEX likes to say, oh, painful, kind of throw people off. It is not painful. It's just keeping their hips abducted. Okay? The big concern with this is that the parents know how to properly put it on, because they can take it off to wash the child. And the other thing is that if it gets soiled, how to clean it, because, obviously they're incontinent, so, you don't want to leave soiled, dirty Pavlik harness on the child, you know, so it would need to be cleaned, and usually.
Middle, right? That's just that.
Yeah, that's just the diaper, but they still can get, I mean, sometimes when they go, it just, may have seen it get, and then obviously you wanna be able, it's cloth, so you wanna be able to clean it properly and put it back on, cause again, insurance companies are not giving people 2 or 3 of these. You only get one, so you wanna make sure you keep it clean and, you know,
You keep it, you keep it for a long time? or
all the
you-
time.
uh,
It stays on all the time, even when they're sleeping. They can take it off, you know, if they're washing them up, but they like it on pretty much 24 hours a day.
Can they how long?
All the way up until the first 6 months of life.
6 months.
With evaluations done every 3 months, they go to an pediatric orthopedic surgeon who does Orlani and Barlow's on them every 3 months to check if they're still dislocating. If after 6 months they're still dislocating, they do not keep them in this anymore. They move them to the hip spica casts, which they will keep them until they're about 18 months to 2 years of age, still checking them every 3 months. And if that's not successful, usually around 2 years of age, they will do surgery. Either plates and screws or something to secure the head of that femur into the acetabulum. Sometimes they even have to do what they call bipolar hip, which is a partial replacement of the head of the femur.
Is there any special positioning in this child? Can it be put down position?
Like you mean to help with head development or, you know, it would be very hard in the Pavlik and even in the hip spike cast. They're usually kept supine. I have not seen them put prone because it would probably be very hard for them to maneuver.
I was gonna say, yeah, looking in that position, keeping them there, they would have less mobility, it would almost plant their face into the bed.
Exactly. It would
Like,
be-
and they
be
wouldn't
very
have
hard.
the leverage to even move
But your book
themselves up.
doesn't say they have to be a certain, you know what I'm saying? I just don't know that it would be feasible to put them in a prone position.
Or maybe you puzzle them like some other puzzle.
Yeah, I mean, you can keep them upright, you can give them, you know, but yeah. So again, education, treatment, sequela, follow-up visits, you know, the sequela would be, you know, obviously making sure they don't have skin breakdown, nutritional needs, because we talked about how immobility can cause to break down, leading to higher risk for fractures. And again, how to put the Pavlik harness on, how to take it off for the parents and cleaning it. And Legg-Calvé-Perthes disease, and then we'll take another break. Legg-Calvé-Perthes disease is very self-limiting. It's actually an autoimmune disorder that occurs sometimes after a viral infection, sometimes after a bacterial infection. What happens is, and sometimes they just don't know why. More common in females. Highest incidence is somewhere, it can be anywhere from 3 to 14 years of age, and I've even heard of cases of 17-year-olds with this. It's 45 males per female, actually. I get more male, I always confuse this because I personally have seen more female patients with this, but it is more male than female, as I have it there. It just always confuses me because almost all the cases I've seen of this have been female, but overall the incidence is higher male than female, so I'm sorry, I'm gonna correct that. And Caucasian, you were gonna say something, Diet?
Yeah, leg calf, right?
Mm-hmm.
That's a disease that run in my family,
Okay,
where my grandparents, probably one had it,
right,
and every one of all of us are girls,
right,
one boy, majority girls, and every one of our boys has it,
has gotten it,
everyone.
okay.
And
So they had a period where they came down with this.
yes, and the thing is, because we're in Jamaica, it is said that it is more Caucasian as you have there,
Mhm,
right? But we're half white,
mhm,
and we're in Jamaica, and when it started happening to all of our boys,
mhm.
none of the doctors knew what it was. So
It is mostly, yeah,
it's a terrible, its progression is, let me say, terrible.
yes,
It's terrible. But like my son got help because when he was there, when I've been watching my sister's son
yeah, so you knew.
perish,
Yeah.
and it happened that they were diagnosed when they were like 7. They
Mhm,
start going to school, they start dragging the feet,
mhm.
they fall over easily, and then
It was one side.
yeah, they start falling without reason, and then they were thinking they pay too much.
Mhm,
And then they start like falling over and hitting the forehead.
mhm.
And then they were saying like, you play too much again. And then they start tipping walking at the 2 point,
Mm-hmm.
then the limping, then
And the fracturing your hip probably.
they didn't fracture, but what
No.
happened, it went, well, probably did, I don't know, because what it went on to, it goes into a phase where they stop walking, and because they weren't being treated, because in Jamaica they said nobody knew what it was.
Mhm.
And people were saying, oh, this is voodoo, this is everything except science, because they go to so many hospitals, nobody knew what it was. Until it got to the point where, while I was here, I am watching the progression, seeing how terrible it is. Nothing on earth is more terrible than that. And then when my son came down with it at 7, I was like, no, stop, we're gonna do something. So this is when I started driving America crazy. And until somebody heard me and said, okay, I know what it is. And then we brought him and he got treated. He actually got the hip spiky
Mhm.
cast
Yeah,
when he
we'll
was 7.
Mm-hmm.
And of course he's not gonna wear it.
Mm-hmm.
So he puts it on when he feels like it. And then when he was 10, they did the surgery with the pin
Yes.
into the hip.
Keep it in place.
Yeah, but now he's fine. If I don't tell you, don't know.
That's right. And he probably regrew all the blood vessels that already put it
Yeah.
off and on again.